with our imaging lecture and lab. We're going to go over hip joint, the femur, the knee joint, and then the leg, and then the ankle joint and the foot. You'll notice, I'll stay on that slide for while I talk it. Next block 4, is the foot and ankle, and then fractures. So rather than doing like a 10-minute thing for that block, I'm just going to finish out the imaging. So there will be foot and ankle stuff that we won't actually need to utilize until next block when we get more into that. But fractures, it's everything, every bone that I care about. I don't care about ribs. Okay. So just an anatomic review, kind of starting where we started yesterday. We have that pelvis, hemipelvis, or innominate bone. On it is the acetabulum, that is the socket of the ball and socket joint. The ball portion is the femoral head, proximal femur, femoral diaphysis. Down at the knee, we have 2 femoral condyles, one medial, one lateral. Got the patella, tibia, and the fibula make up the leg. Down at the ankle, we have its articulation with the talus. Calcaneus is our heel. The metatarsals going into the phalanges. So let's start zooming in on that hip joint. So within the hip joint, we got that acetabulum and the femoral head. You'll notice that there is the ligament of the head of the femur. It's cut in this image, but you'll be able to appreciate that on some x-rays as kind of a divot in the head of the femur. We talked about yesterday how it would be like a cue ball. But when you look at it on radiograph, you might actually see a divot in that cue ball. That's normal. That's where that ligament attaches, and it just happens to be more noticeable in some cases. We also talked about the neck of the femur, and then the capsule is very interesting in the hip. It actually goes all the way back to the end of the neck of the femur. Pausing one moment. I don't see them. Oh, I found them. You found them. Goes all the way back. So that is the portion here. That's the capsule cut. Makes a difference when we're doing surgery in the hip because anything in that area is going to be bathed with joint fluid, which changes how we do things. Ooh, I get to do individual erasing now, not group erasing. Okay. So when we start looking at the hip, that fovea is what we were just talking about, being that notch that you can see in the femoral head. A little more obvious here. The nice cue ball that makes up the femoral head should be a nice rounded surface. Coming down, we have the femoral neck. The acetabulum is the socket. Let's see here, what else do I need? Greater trochanter. Oh, the pen. I see what I do wrong now. Touch that button. Okay. Greater trochanter there, out laterally, like we talked about yesterday. It's the farthest part out on our hip. The lesser trochanter is this goober down here. Ischial tuberosity, that's what we sit on all day long. Talked about the fovea, which is where that ligament attaches. I take this off right there. It's a little easier to see that fovea, the notch. And then my image doesn't have it, but somewhere in here is going to be that pubic symphysis. Bless you. While I'm on that image, do I need to go over anything again? Okay. Take that all off as I'm in PDF and we'll get to. when we get a lateral of the hip, we do not get it as if we were shooting just straight lateral. That's not going to give you a very good image of the hip. So we do what's called a frog leg lateral. They are taken, they look like they're in that position. So they put their leg up like they're a frog, and they shoot the lateral from medial to lateral so that we can capture that hip without the rest of the pelvis or the other leg in the way. So that's called a frog leg lateral. It's the most common kind of lateral of the hip. And when we look at that, things get a little weird. So down here is the lesser trochanter, but kind of on the same side, which is weird for us as humans, is the greater trochanter. It's just because we've taken that bone and we've made them so that they're parallel and they lay on top of each other. We have the femoral head. Fovea is not nearly as visible in this because it's on a different surface, and so it overlays with the rest of the bone. And then we have the acetabulum. And the ischial tuberosity sticks there at the bottom. Then we get into the rest of the pelvis, which makes kind of things overlap and whatnot. This is a slight variation on that. Again, showing that the trochanters end up very close together just because of how that bone is tipped. I brought this guy in for a reason. I do. So we're shooting the X-ray kind of in this plane, so the trochanters are on the same plane, flat together. Okay. Set him down. Don't want to dance with him the whole time. It'd be weird. Because of all those overlapping bones, we do occasionally need to go to CT to be able to look and get three-dimensional imaging. We talked about a couple pathologies yesterday where that three-dimensional imaging would be helpful, like impingement. So we can use the 3D images to help us understand how the bones lie relative to each other. On this particular slice, we kind of caught the acetabulum right dead in the middle. So the acetabulae, both femoral heads. On this side, you can start to see where the fovea is going to be by that extra thick bone. We don't have either a great on this side, we don't have a great view of either trochanter. A little better here with the greater trochanter. This little blob is the lesser trochanter, but it's hard to appreciate when it's not attached to anything. But if you scrolled forward and aft, you would be able to see that. And then we got a cross section of the rami as well before they made that nice typical donut that we're used to seeing. We did actually get a very degenerated L5 into this particular CT as well. This is an axial cut of both pelvi. Gives us that good cue ball look to the femoral head. Acetabulum. These are greater trochanters on as far lateral as we can go. We got pubic symphysis on this, which can help us in some pathologies, helping assess that. And then we have the sacrum. There's a positive arrow sign on that. If you overanalyze that, there is a little line right at the tip of that arrow. Not sure if that's a sacral fracture. I try not to overanalyze it, but if you think you're seeing things, maybe you are, because there's an arrow sign. I picked this one because of the rest of the picture, not necessarily that. Any questions on what we're seeing here before we move on? Excellent. Switching over to MRI. We like the hip MRIs. We used them a couple times yesterday when we were looking at blood supply, when we were looking at the density of the bone. We need them to assess the labrum. When we look at the labrum, This is a non-contrasted study, so you're gonna have, actually it's contrasted on this side. So maybe this person has a problem on this side. We're looking at the labrum superiorly. If we get a different cut, then we could see it elsewhere. It's not as good on the inferior border in this, but you can get some information. You would probably do better doing the sagittal cut on that. Let's see here. So how did I determine that it's contrasted? So we can see that bright white fluid there in the joint. It's different than on the other side, where it's just a dark color. What else can we tell from this picture? Oh, we can kind of see a fovea where that ligament attaches. We can tell the bone density, whether there's any bone edema, being that white fluid within the bone, which I don't see here. You can also check the texture and the signal in each of the muscles, looking for maybe like that tendinitis we talked about yesterday, would be fluid signal within the tendons. Muscles, we could look for muscle tears, either complete or incomplete. So good soft tissue. So here is that arthrogram. Remember, I tend to spell this out because an MRA could be an angiogram. So watch my A's, angiogram versus arthrogram. If I'm talking, I probably want it in a joint and not in a blood vessel. So watch for that angiogram versus arthrogram. How do I tell that that's what this is? We've got that nice flash of white fluid. Tells us that we've got contrast within the joint. Here we've got a zoom in, so we've got a little bit better view of both of the labrum. Labra. Yeah, sure, we'll go with that. We could follow that by scrolling forward and backward and seeing kind of how that consistency changed. There's a notch in this one. If you're seeing that, you are true. You see that notch. There is a normal variant where there is a little notch there. It has to do with where it goes from bone into flesh. So you can get a normal variant notch there. So really rely on your MSK radiologist when you start seeing subtle findings like that. Talked a fair bit about the head and the neck. I like this picture just because this green dotted line, that's where the joint capsule extends to. Again, that plays a part in how certain femoral neck pathologies heal, because when things are subjected to joint fluid, that joint fluid turns over and moves away healing properties. So things like complete femoral neck fractures take a long time to heal because of that aspect. Greater trochanter, lesser trochanter, we started talking about those yesterday. Diaphysis of the femur, we'll talk more about that next block as we go into fractures and learn about those. Coming down to the knee, we have the medial and lateral condyles of the femur. That area outlined by green is called the trochlea. We had one at the elbow, and now we're talking about the one at the knee. Cartilage goes up that entire green line. That's all behind the patella. And that is cartilage that we need to look at when we start considering patellar pathology and what's going on behind the kneecap. Let's see here. Medial lateral condyles. Yeah, pretty good with that. So we've talked at length about the hip, moving down through the diaphysis of the femur. I don't like this one as much because they split the femur up onto two plates. Standard is now that we do it on one plate, unless there's some positioning reason that we can't stick it all on one picture. Mostly because if you can imagine something fractured in the middle and having a rotational difference, that would be hard to picture if you don't have the whole femur on one x-ray. Does that make sense? There's some questioning looks on that about what I mean. Just got to catch it all so that we can make sure that it didn't break in the middle and then part of it rotate. Okay, lateral of the femur. catches us a lateral of the knee, and it's still got that frog leg appearance of the proximal femur. And then we'll go on to the knee joint. I really like this picture in terms of your study purposes because it's a little better because of its three-dimensional projection. I'm going to bring in with me my knee model that has all of the ligaments. But for those of you who need to kind of understand this in 3 dimensions to understand, this is a better picture for this, but my model is really better. But I like this picture in terms of showing where the ligaments are attaching and where cartilage is and meniscus and all that stuff. So what am I taking away from this? So we've got the MCL, we've got LCL from the lateral condyle down to the fibula, quad tendon, patellar tendon. Got some cool menisci in here. And then we have PCL. Remember, it's called P because it goes to the posterior. And the anterior cruciate goes to the anterior. Dig that neuron up. The anterior cruciate ligament attachment is underneath the patellar tendon. Remember, they're both named after where they go, not where they start. Cue off there. Okay. So that brings us to the knee joint. So when we look at the AP of the knee joint, it's important to separate medial from lateral. So I do that by finding the fibula. So fibula is lateral. There's a really bad outline, but that bone there is the fibula. Patella, we need to identify the patellar shadow. It's a triangle. It's a triangle in both dimensions. So here in a second, when I show you a sunrise view, it's a triangle in that dimension as well, which is kind of cool. Medial femoral condyle. Now that I've identified lateral, I can identify my medial condyle and my lateral condyle. Here, these 2 mountains in the middle are our tibial spines. And then a phrase that we will use more next block, but it's kind of important to understand now, is these flat surfaces at the top are the tibial plateau. So think of that. Typical map plateau. Geology, sure. Flat top, tabletop. That's what we're talking here. Once you get those tibial spines out of the way, the rest of it is very flat. So that's how it earned its name of tibial plateau. Any questions on any of those items? Okay. From there, we move to the lateral of the knee. In a well-captured lateral, both of the femoral condyles should overlap. Here, they're not perfectly overlapped. You can actually see both of them. But it doesn't mean that you know which is which, so don't go jumping to that conclusion. Take that mark off. But here are those overlapping condyles. I think on your picture they're a little better overlapped. See? Yeah, not actually. Okay, then we go patella. This is the one dimension. The patella is not shaped like a triangle. The proximal fibula, it doesn't help us as much as it did in that AP, but here's our proximal fibula. The tibial tubercle or tuberosity is this bump right at the front. That was a terrible line. That bump is the attachment to the patellar tendon. We'll get to talk about that when we get to our pediatric knee conditions lecture. And Osgood Schlatter. Let's see here, quadriceps tendon. Let me take my patella marks off so we can appreciate that. So we're looking for the dark lines. You see them a little bit more there. I think yours has a, yep, so look for the dark, not the light. The light is fat and other joint fluid, so you're going for the dark, not for the light. And then quadriceps tendon is at the top, superficial. On yours you have white deep to that. Quadriceps tendon is the superficial dark part. Patellar tendon, quadriceps tendon. Anybody need me to go back? So there's that sunrise view. So it's captured by having the patient bend their knee, and it's along this line. So you're catching the patella sitting in the trochlea. So the trochlea is here, and it captures, it holds it's the trough that holds the patella when you're extending and flexing your knee. So it does have a lot of articular cartilage that articulates with the posterior surface of the patella. And based on where the patella sits in the trochlea can help us understand how strong the medial quads are. So the more pulled over into the middle it is. Okay. With this is lateral and this is medial. You guys may be like, really, how'd you figure that out? So it has to do with the shape here. So the flatter one is usually the more medial one. That is not a factoid I expect you guys to understand at this point, but it'll help you as we build on that when we talk about patellar instability. That the smaller mountain is on the lateral side. It is. Okay. I'm going to say interesting point because you're right. It says that this is lateral and this one's medial, and it makes me upset. Okay. So because you don't have to know it right this instant, I have some better radiographs that we'll talk about when we talk about patellar instability and maltracking. That'll make more sense. So ultimately, how would you mean to know? You would need the fibula. Okay. I got no fibula. That was terrible English. I'm sorry. I'm amused now. I'm going to go find a different picture for next time. I didn't bring my book to write down. Okay, CTs. So CTs really in the knee have to do with fractures and fracture identification. So I would obtain one if I were worried about fracture or those loose bodies. So loose bodies and CTs are kind of a pairing. Here, this is our axial cut, our frontal cut, coronal, and then our sagittal over here. The cool thing about CTs now is that they do 3D reconstructions. Those can help a lot with understanding where fracture fragments, not so much alignment. So if we're worried about 3D alignment, we have to do different kinds of studies, which are some of the newer modalities. So they're basically hip to ankles so that you get the whole hip and the ankle, and that helps us understand the entire leg in terms of some deformities that may be occurring. Normal MRI. Scroll down. Proximal fibula. Okay, so here on mine, I do not have a proximal fibula, but I am going to make some leaps. Hope that they're better leaps than last leap I made, right? I'm going to call this lateral. How I got to that determination, oh, I pushed the button, is that structure right along the lateral side is more consistent with the IT band than any medial structure, which would make this medial collateral ligament. This is the nice black structure, so it's bordered by white on both sides. You got the nice subcutaneous signal, and then a nice black band, and then you've got a white and gray signal deep to that. In terms of location of the lateral collateral ligament, that extends from that wrinkly lateral side. There's the bone actually has attachments there to the fibular head. You don't label those on your picture, so that's good. Okay, so proximal fibula, I don't have it, but if you need me to help you find it on your capture, I can. We can say the condyles, if there are articular surfaces. Tibial spines, two structures in the middle. This one has one, yours has two bumps in the middle. The tibial plateau, so that's this entire surface here, the flat tabletop at the proximal tibia. Femoral articular cartilage. I think I'm going to start with we'll go ahead and do cartilage. So femoral articular cartilage, yes, excellent. So there is a gray shadow on both of these bones before you get to a bright white shadow. Pull that off. The gray is the cartilage. The white is joint fluid. A little bit more obvious on yours. How would I describe that? Mid-gray? Sure. Just said mid-gray. We'll throw out shades of gray right now. Yep. No lusty movies for me. Cartilage. Your tibial cartilage is much more obvious than mine. But the tibial cartilage is that same density. So once you found it on the femoral side, the tibial side, again, gray outline. Caught a little of the, right there. Okay. Being the cartilage. So what's the stuff in the middle? That's the menisci. So menisci, yep, yeah, I can do that next. So these are the black triangles. And this one looks more like a horn. It's a very elongated triangle. That's consistent with yours as well. So everything that's smashed between those two cartilage surfaces, it's a black triangle in both weights. So my weight and the weight that you guys have in front of you. So PCL and ACL. Kind of talked a little bit about this yesterday when we got to ACL. They are not awesome in this view because they're cut in cross section. So we have those nice thick bands and they've been sectioned, caught right in the middle. So they'll appear as circles rather than those long black lines that we saw yesterday. We're looking at different cuts. So here's that capture that has the tendons in it again. Maybe it helps you a little bit to see where those tendons were on the x-ray by switching modalities here with how superficial the quad tendon is. Patellar tendon. This particular cut has that ACL going from posterior to anterior. It also has a little bit of a cut of the PCL going from, it's not necessarily anterior to posterior, but posterior to posterior, ends posteriorly. Now, if you're thinking, well, where's the rest of the PCL? It's okay, you can't see it, but it is there. So how do I know that the PCL is intact? Because it's still under tension. So it's kind of being pulled. When your knee is extended, as when you are having an MRI of your knee, the PCL is not fully on tension. So when you get to a cut that has just the PCL, it'll almost have a bow, and then it'll attach. Half of a heart. That was good imagery I just decided to use there. So that is what you will see when you have an intact PCL. We do have an axial cut that can look, again, at that same view. We were looking at the sunrise view. We're looking at the cartilage surfaces on the front of the femur and the back of the patella, looking for potholes and similar things that would be painful or uncomfortable or catching symptoms from when a patient flexes and extends their knee. It's where the patella is forced into the trochlea, and it would cause, if there are potholes in this area, that would cause the patient's symptoms. Okay, leg. We've talked a little bit about the knee. We have the diaphysis of the tibia and fibula coming down to the ankle. Some important words that we have here are the malleoli. The one on the tibia is the medial malleolus, while the one on the outside, on the fibula, is the lateral malleolus. We like to talk about those in complex ankle fractures. There is another malleoli, in case you wanted to know. It's the posterior malleolus. It's this notch right here. So there are 3 of them. So next block we will start talking about trimalleolar ankle fractures. And that's where that phrase comes from. Medial, lateral, and posterior malleoli. I like this one a little bit better because the AP of the tibia, it's an AP tibia fibula. It's captured on one plate, so I can see all the way from the knee, all the way to the ankle, make sure there's no angular anything. Have an AP of the knee proximally and an AP of the ankle distally. That's what defines this is a good X-ray. Same thing laterally, so we've got all the way from the knee to the ankle, defines that as a good X-ray. In our occupation, you may end up seeing some of these types of studies. So nuclear medicine studies, this one is of the tibia. So this is that bone scan. Remember, very sensitive, very non-specific. I can tell you that there's something going on there, but I can't tell you what it is. So just because it is there does not mean I know what it is. It could be a tumor, it could be a stress fracture, it could be a cyst that's healing. There are a lot of things that it could be. So just because it's there does not tell me exactly what it is. So when would you guys use a bone scan? So the last time I used one was when I had a patient that had stress fractures in more than one area. So they had March fractures and shin splints that we were suspecting were also stress fractures. So bone scan is usually a whole body study, and that I was fishing for other places, femoral neck, namely, to see if this patient was suffering from additional stress fractures that would change, one, their ability to continue to be in military. So if they're in basic training, AIT, second phase of training, and they have that many stress fractures, that's not a good sign. It's painful for the patient, but not awesome medically either. Okay, MRI. I'm going to employ the MRI for the same reasons. So this particular capture here is of the tibia because I'm looking for those stress fractures, which is what I captured in that far right set of images at the arrow signs. So that bone edema we started talking about yesterday, all that extra fluid in this image here, that's bone edema, where we're looking for stress fractures. This just has the weight flipped, so showing us that same lesion area. how that area became agitated would have to come from a clinical history. This person is nearing skeletal maturity as well, so adds additional fun to looking at why they have stress fractures. Then we'll move on to the ankle joint. Wow, there are a lot of ligaments around the ankle. Medially, we'll group them all as deltoid. Laterally, we actually start to name them because where they are matters, but there are three main sets that we care about. They attach the fibula to the talus, the fibula to the calcaneus, and the fibula to the talus anterior. So posterior and anterior talofibular ligaments with the calcaneofibular ligaments. When we talk about ankle sprains, I'll walk you through in what order these tend to disrupt. It's predictable. Let's see here. High ankle sprain ligaments. There, so that's the inferior tibiofibular ligament. There's one anteriorly and there is one posteriorly. Well, let's see here, what else do we have? The Achilles has been cut in this picture. The only other one that we care about is between the second metatarsal and the bones that are related around there. If you guys have heard of a Lisfranc injury pattern, we'll talk more about that when we get to next block. But that's the only other one that really comes into play in terms of things that you need to know, and we have better slides on that. Lisfranc ligament later. Okay. So now we have another picture that we need to go over. So medial malleolus, and that's on the tibia. Lateral malleolus, fibula. I'm going to take these marks off so that I can do the talus. So the talus in this dimension should be a box, pretty close to a box. While those of you who were outlining that talus said, what's going on there? That is a something. So there's some kind of bone change there medially. Could be somebody who chronically ankle sprains. We'll learn more about that next block. Okay, deltoid ligaments. So we can't actually see them. We infer their location. They're going to go from the medial to this bony prominence here. Deltoid ligaments. We can't, again, see the ligaments out laterally, so we're going to infer. ATFL. If you want to put on the others, that's cool. I don't, doesn't matter. They're there as well. Just do it properly overlap. Okay. Another word that I need to introduce to you at this point is one that we use most in pediatrics, but it's the opposite of a plateau. So this area right here is the plafond. So again, it's a big flat area, very similar to what we talked about with the tibial plateau. It articulates only with the talus, but in a pediatric patient who has physis there, an epiphysis, it becomes important to the articulation with the talus in terms of developing osteoarthritis and stable and unstable fractures. Anybody else need me to outline anything before we move on to the lateral? Mortise view. Okay. So the key is here. So that how that is overlapped right there. When we go to the mortise view, see how that window opened up? Okay. That's what makes it different, is there's actually an angle on the foot that allows us to look straight through that joint. So why we're talking about the mortise view is that helps us tell whether the ankle is properly seated within the joint. So this talus portion should be dead center. It has cartilage all around it. So in a stable ankle, these distances will all be equal, meaning that it's well seated within the joint where it's allotted. If you see widening of one of those, then that indicates that something is unstable because it's not seated properly. And then we'll move into the lateral. So overlapping malleoli. So on a lateral, it's really hard to say where one malleolus starts and where one stops because they're all sort of in this general area. So if you can follow any lines through that, it's not important to me that you be able to identify which one's the tibia and which one's the fibula. It's not particularly helpful. I just need you to know that that's the general area that those malleoli are existing in. The posterior malleolus, it's the section right here. There is more to it, but that's just the most obvious part. The talar dome. I like this one because it makes sense. Like we named something because that's what it looks like. So that arch right there is the talar dome. It's what allows you to flap your ankle. Achilles tendon insertion is this prominence on the superior posterior calcaneus. Or calcaneum, if you're British and writing things on the fly. Achilles tendon plantar fascia insertion is the prominence on the plantar surface of the calcaneus. You can almost see some tissue going in there. Of course.
This is where the
Plantar fascia attaches. So this is the plantar fascia. It's basically I see a change from one gradation to another. That's sort of what I see on yours too. I see kind of 3 gradations of gray right in that area. The one in the section in the middle is the plantar fascia. Okay. Cuboid is captured here inferiorly. And the navicular is superior. We get a little bit better view when we start looking at the foot. That's how those would translate if I needed to get an orthogonal view. Look for that. Go ahead.
Is there a chance you could put out the posterior malleolus on that?
So the most obvious section of it is this part right here. There is more to it, but that's the obvious part of it. There's a lip of it that catches, but you can't appreciate it here because you're stuck on that bold line there, right there. Anything else? Anything I need to outline again? Okay. Yep, I'll show it again.
I'm sorry, I missed it.
It's okay. Okay, so shiny object syndrome happens here. So this border here is the most obvious part of it. There is more to it. I don't know if this guy has a good posterior mount. Not particularly, but if you want to come look at his leg's an okay approximation. There's a lip that extends a little more inferiorly, but finding it is not critical at this juncture. It's somewhere under the end of the line that says lateral malleolus. Okay, CTs. We use these again a lot in fractures of the ankle for reasons kind of like we just saw. So we could also be looking for loose bodies. That would be another good utilization of my CT. Those are really the ones I like the most. In terms of identifying structures, this one's pretty cool because right where they captured it, that's the medial malleolus, lateral malleolus. We've got that talus with the top of the dome, and this is all calcaneus. And here we've got talus, calcaneus, and this is actually a little bit better. So this is before you get to the lip, but there's that posterior malleolus again, if I were looking for a trimal fracture. One moment, drew a lot of lines. Okay, and then we switched to an MRI. I did throw in, I don't remember throwing that in, that was cool. It kind of shows the compartments, what's where. This is a pediatric MRI. Just for those of you who care why there's two parts to their tibia. What would I use this for? Ankle sprains with laxity, where I'm thinking that one of the ligaments is out. I would prefer an ultrasound over an MRI if I thought their Achilles was out. Lisfranc ligament. So some of the ligaments are my preference here. I would go ahead with that study. I guess you could look like a gastroc tear. So I was coming back to that image that's on the right there. We were looking at something wrong with gastrocnemius. So we could capture that in an MRI as well. And then we'll go on to the foot. So talus stacked on top of the calcaneus, navicular, then all the cuneiforms, medial, intermediate, and lateral. And then the cuboid's the big cube that holds space on the side of the fifth metatarsal. We've got our metatarsals 1 through 5, and then phalanges, the same rules apply as they did in the finger. Great toe only has 2, everybody else has 3, even if they're cute and little. Okay, this phrase right here is a little bit controversial. Okay, so this is a dorsal plantar view. It can also be called an AP view. Don't get wrapped around the axle on that particular thing, but know that that's why it's labeled that here, is I'm talking about how it was shot in reality, because if you remember that, our Vitruvian man, he's actually got his feet pointed down, which I can't do without falling off the podium. But his feet are plantar flexed, so that's how we get the AP equivalent. But in order to shoot it, he's not in that position, he's like this. Go through there, okay? If you want to sound cool with ortho, you can throw that phrase out there. Okay, cuboid, just remember it's the big block that holds out the outside, or cuneiforms. Hold up the middle, navicular. It's boat-shaped too. I think this is probably the better view to see that it's boat-shaped. Remember that both with the wrist and here, the navicular is boat-shaped. So it's got that root, nabby. Calcaneus and talus are stacked on top of each other here. So you've got that, the tibia and the fibula kind of all muddled together. What else do I need to know from this particular picture? Moved it over to an oblique for the rest of it. So I'll do the labeling on the oblique because that's what you guys have. So, an oblique. We use this to help be able to separate out the tarsals. So the difference between the previous image and this one is that I can start seeing between those tarsals, which is why this particular view is a little bit better than all those overlapping tarsals in the last view. So, get to do names again. Okay, cuboid's on the outside. Lateral, medial, intermediate and medial cuneiforms. I really wanted to get to them, but I was thinking they're overlapping. It's awesome. Navicular, talus, calcaneus, metatarsals. Oh, those are fun. So we've got a little bit of overlap here between 1 and 2. Otherwise, going through and outlining those. Remember, this is exactly what my eyes do when I go over an x-ray. That's why you do it. So I've now visually outlined the metatarsals, tibia, fibula. I don't care if you find the end of the fibula. It's there somewhere in the talus, even in yours. Sort of see the end of it. It's not critical. Okay, base of the 5th metatarsal. This is a stress fracture area. So remember that the base is the proximal side. The head is the toe side. Okay. Metatarsal phalangeal joints. And sesamoids. Hold on, I gotta get all this stuff off of that. There are 2 in most humans. They should just align just proximal to that metatarsal phalangeal joint. There's a little more overlap than mine. It's still present. Just a second to take all this off. Finish up with the advanced imaging of the foot. Okay, a true lateral. Not as nice for looking at the metatarsals. This is just like the hand. If we get them all, we could get a good x-ray. They're all supposed to be lined up on top of each other, so it doesn't help there. It can help us if something is displaced or prominent, like a tarsal boss. That's what we call it when you have that bump onto your foot, right around here. Toes should align too, so it's not great toe. Helps us with this location of the sesamoids, which should be right there under that bony prominence of the metatarsal head. We use it a lot for calcaneal fractures and talar body fractures. CT recon, so I would use those again for fractures, loose bodies within the ankle joint. If I thought that there were fractures of the tarsals, particularly the talus, foot, CT may be helpful. If you're worried about kind of where things are, maybe that 3D reconstruction can help you. I think it looks cool. It's like one of those ultrasounds where you get to see baby's face. MRI. So because of, just like in the hand, all those ligaments, there are lots of them. So sometimes you need to go to the MRI of the foot to help you start tracking down what's where, especially if you have some laxity or some chronic pain that is just not getting better, to be able to tweeze out maybe some more subtle findings like a ligament fracture, tendon insertion problem, stress fractures, those kind of things. An MRI. I will admit that MRI of the feet is probably my biggest weakness, just because there are so many ligaments. Here's a sagittal view. That is the end of this presentation. Okay, so it's been about an hour. Please go ahead and take your bio break.